Hi, I'm Ollie Flower. This is a Pecha Kucha specifically about complications post-aneurysmal subarachnoid hemorrhage, except vasospasm, which is covered in another PK. It's part of 5 PKs discussing aneurysmal subarachnoid hemorrhage. I'll talk about some more reasons why your patient may deteriorate and broadly divide these into medical and surgical causes. If your patient has a neurological deterioration, try not to focus on one thing and initially think broadly about all the potential causes. These include metabolic causes, including abnormalities of carbon dioxide, sodium, magnesium, glucose, temperature abnormalities. It could be seizures, it could be drugs responsible, or it could be a new intracranial event or intracranial hypertension. If there's a clinical seizure, think of a rebleed. In unexplained coma or neurological deterioration, think about non-convulsive seizures and get an EEG. Risk factors for developing early seizures include MCA aneurysms, thick clots, rebleeding, infarction, poor neurological grade, and clipping rather than coiling. It's not clear if clinical seizures impact on outcome. Non-convulsive seizures are a strong predictor of bad outcome. Phenytoin prophylaxis appears to be associated with worse outcomes, especially when treatment is prolonged. 3 days of phenytoin prophylaxis appears as effective as 7 with less side effects. Phenytoin is the most prescribed AED, but there's no compelling evidence to use this over other AEDs. Hyponatremia is common. It occurs in 30 to 50% of cases, usually due to pituitary adrenal dysfunction. The definition for this purpose is less than 135 millimoles per litre. It typically occurs between the days 3 and 14 and usually presents before the onset of vasospasm in patients who go on to get it. In terms of causes of hyponatremia, SIADH and cerebral salt wasting are the 2 commonest mechanisms. It's hard to differentiate in clinical practice between these because they both cause hypotonic hyponatremia and inappropriately high urinary sodium content. Cerebral salt wasting is thought to be caused by increased secretion of natriuretic peptides, probably mediated by activation of the sympathetic nervous system, leading to excessive excretion of sodium in the urine. High intratubular sodium content then causes an osmotic gradient that drags water into the urine. Consequently, CSW is associated with intravascular volume contraction. Conversely, SIADH is caused by excessive secretion of antidiuretic hormone, leading to free water retention. As a result, SIADH is associated with normal or slightly expanded intravascular volume. Discriminating between CSW and SIADH is important as they require different treatments. Fluid restriction, as usually recommended in cases of pure SIADH, is potentially dangerous in patients with SAH and vasospasm, therefore in practice this management is rarely used. Also, CSW and SIADH may coexist in the same patient, so careful repletion of volume losses and assessment of circulating volumes necessary in all patients. Early treatment with mineralocorticoids does work for hyponatremia, and Flugelcort has a better side effect profile than hydrocortisone. Hypertonic saline may also work. Albumin may ameliorate excessive fluid and sodium losses in the urine, but its overall effect on outcome is unknown. And generally, vasopressin receptor antagonists like conivaptan are avoided because they can cause dangerous hypovolemia. Myocardial injury occurs following subarach and is thought to be related to sympathetic stimulation and catecholamine discharge. Elevations of troponin levels occur in approximately 35%, arrhythmias occur in 35%, and wall motion abnormalities on echo in about 25%. There is a clinical syndrome of chest pain, dyspnea, hypoxia, cardiogenic shock with pulmonary edema and elevated cardiac markers that occurs within hours of subarach and has been termed neurogenic stress cardiomyopathy or stunned myocardium and may contribute to sudden death in up to 12% of patients. The management of this syndrome should focus on supportive care that balances cardiac needs with the neurological goals. Get a baseline ECG, cardiac enzymes, and an echo. If there is myocardial dysfunction or hemodynamic instability, strongly consider some form of cardiac output monitoring. Avoid hypervolemia. If you have concurrent vasospasm, this can be a fine line to walk. Rebleeding. This is bad. If it happens, there's a 12-fold reduction in the probability of a survival with functional independence at 3 months, even if you correct for everything else. It occurs in 1 to 3% of patients. The risk of re-rupture is associated with the degree of aneurysm occlusion after treatment. Poor grade and larger aneurysm size are also risk factors. ISAT suggested that rebleeding was more likely after coiling compared to clipping, but other studies haven't shown this. Hydrocephalus is an active distension of the ventricular system of the brain due to altered CSF flow dynamics. It's an important cause of an acute neurological dysfunction after subarachnoid hemorrhage that is treatable. It occurs in 15 to 30% of patients acutely, 40% of whom are symptomatic. It's either caused by obstruction of CSF flow by blood products or adhesions, causing acute hydrocephalus, or reduction of CSF absorption at the arachnoid granulations, which typically presents 2 weeks or more later and is more likely to be associated with shunt dependence. The risk factors for hydrocephalus include intraventricular hemorrhage, posterior circulation aneurysms, treatment with antifibrinolytic agents, low initial GCS, hyponatremia, hypertension, older age, but the type of aneurysm treatment does not seem to predict hydrocephalus. Aneurysmal subarach-associated acute symptomatic hydrocephalus should be managed by CSF diversion. This is typically by external ventricular drain, although some places use lumbar drainage. EVDs are necessary but carry the risk of ventriculitis, especially when in situ for more than 3 days. Usually attempts are made to reduce dependence on the EVD and remove it as CSF flow normalises. Weaning an EVD over more than 24 hours does not appear to be effective in reducing the need for ventricular shunting. Aneurysmal subarach-associated chronic symptomatic hydrocephalus should be treated with permanent cerebrospinal fluid diversion. Routine fenestration of the lamina terminalis is not useful for reducing the rate of shunt-dependent hydrocephalus and is therefore not recommended. So that's the end of another Pecha Kucha. If your subarachnoid hemorrhage patient deteriorates, think broadly and see all the potential causes. Don't forget non-convulsive seizures, actively look for cardiac manifestations of subarachnoid hemorrhage, and look for and treat hydrocephalus with your neurosurgical colleagues. Thanks for listening.